so that we will take that into consideration for the next time. So let me introduce today's speakers, the expert speakers. So the first one, Dr. Iman Heweli for IPC. Thank you, Iman, for your time and sharing your technical expertise. And then after that, after Iman, it will be Dr. El Taib Al Said for vaccine. Dr. El Taib, I guess he hasn't joined yet, but we are expecting him to join anytime soon. So it will be starting from myself. I'm Dr. Chiori Kodama. I'm a medical officer, and I'm serving here for WHO EMLO. We are based in Cairo, Egypt, and we oversee 22 countries in Middle East and northern part of Africa. And I serve for the health emergencies program, but when it comes to our disease response and preparedness, that we are all working across units and departments. So let me start sharing my screen. I hope you see my screen in the presentation mode. Yes? Okay. So my colleagues are nodding and saying yes. So let me begin. So yes, so MPOX, the case management, safe and scalable care. Now, actually, as many of you might remember, 2 years back, we also experienced the outbreak and also upsurge of MPOX cases. At that time, it was called monkeypox, but after WHO renamed this disease as MPOX. So this is the MPOX, the safe and scalable care that WHO recently published this document, the Global Strategic Preparedness and Response Plan for MPOX, covering the 6-month period from September 2024 to February 2025, provides the framework for public health preparedness and response to the monkeypox, MPOX emergency. So this one was developed with input from member states and partners and outlined the urgent actions needed at global, regional, and national levels. So that's why we thought it could be beneficial for us and for you to share this document so that you can take a look. And I have also enclosed a link for this. So when it comes to safe and scalable care, this is the action point recommended by WHO. So MPOX case management and the IPC. So we have developed the interim guidance in 2022 jointly with IPC team. So the number of recommendations, so the special emphasis was placed on the management of mild or uncomplicated MPOX, and also the infection prevention control at healthcare facilities, and considerations for specific populations and caring for specific populations. So this is how it looks like. So I have also, again, enclosed a link for this overall clinical management of MPOX algorithm. So if you are clinicians or nurses or somebody like an expert working in the hospital settings, then first, you have to screen, you have to suspect that this patient could be MPOX. So you need to know how the characteristics of MPOX or the case definition of MPOX is like. So the first, it will start from the screening. The person of any age presenting with acute rash, that see characteristics of MPOX rash, that the characteristics of MPOX acute rash is stated on the top left, the box. And one or more of the following signs or symptoms: acute onset of fever and lymphadenopathy, and headache, myalgia, back pain, and asthenia, like really like you're drained and you don't have any strength to move. So if this is yes and no, then you will follow this the patient care pathway. But it's very important for you, and if you are someone that who is part of the WHO, part of the mpox case management, IPC, you need to understand all this the algorithm patient pathway. So the screening that the characteristic of mpox acute rash is that rash in sequential stages, macules, papules, vesicles, and pustules, and the clustering over and disformative regions over a period of 2 to 3 weeks. And the rash usually starts on the face and or genitals, and the lesions can range from 1 to a few, and in severe cases, several thousand, and can involve mucous membranes, conjunctiva, and the cornea, the eye lesion. And typically, all lesions are at the same stage and are centrifugal and extending towards palms and soles. So the screening, this is basically how you screen the patient. And if the patient is meeting this criteria, yes, then the patient will be entering the mpox care pathway. The patient should wear a medical mask and the distance of more than 1 meter between patient or directed to a single room. So it will be more explained by Dr. Iman for IPC session. The symptoms and signs, the infection progress in 2 phases. The initial phase of febrile illness typically lasts for 1 to 5 days, during which time the patient may experience fever, headache, back pain, muscle aches, lack of energy, and lymphadenopathy. And the second phase, typically after fever subsides, fever disappears with the appearance of characteristic rash. The rash presents in sequential stages, macules, papules, and vesicles, and pustules, and umbilication before clustering over a period of 2 to 3 weeks. But as you can imagine, this febrile illness, headache, back pain, muscle aches, lack of energy, it can be anything, right? That when you are just tired and when you are just having just regular cold, you also may have this kind of clinical symptoms. So it's important for you to understand the characteristic rash. So that is why WHO has developed and produced this atlas of mpox regions that with lots of photos. So I would strongly recommend if you are interested and if you're a healthcare worker to visit this site and also to have this atlas in your mobile, downloaded in your mobile, so that once you suspect a patient at your health facilities, you can quickly refer to those photos from the atlas. So the differential diagnosis, of course, it's not only limited to chickenpox or measles, but also the chickenpox or measles, it can be also very much mixed up with mpox clinical presentations. However, mpox, the rash appearance, that they can be present at the same stage. That if the rash is at the macule phase, that all the rash, that it can be 10 to 20, it can be 100, it can be sometimes like exceeding 1,000, but they are supposed to be at the same stage on any area. And on contrary, chickenpox, as you can see that macule, papules, vesicles present in several stages at the same time. And the measles, that maybe some of you may have seen the measles patient, but the non-vesicular rash, non-vesicular, so the rash is flat and more bright red in different stages. So the rash development for mpox is slow and discriminating over weeks. And the rash distribution is starts on head, more dense on face and limbs, and appears on palms and soles. And the classic feature is lymphadenopathy. So the mpox regions, the rash which develops in mpox may resemble other infectious diseases or other conditions, including varicella zoster virus and also chickenpox, measles, scabies. That in many the conflict-affected settings, we have been receiving many cases that the mpox or scabies, the mixed up or resemble. So other bacterial skin diseases and also the soft tissue infections that can be also mimicking mpox lesions. And the lashing mpox generally progresses slower and is more peripherally located and present at the same stage on any given area. And the severe lymphadenopathy, swollen lymph nodes, is a distinctive feature of mpox and generally develops before the lash. So again, this is the Atlas of Mpox regions developed by WHO in 2023, and I have enclosed a link here. So the Mpox, okay, so it seems like I only have 5 more minutes. The last example, so as you can see that this actually looks very characteristic for Mpox. The active lesions on extremities and the pseudo pustules and the mimicking target regions. So this is a surveillance case definition for mpox, suspected case. We all know that this is the case management IPC and the vaccine webinar. However, if you are clinician, nurses, if you are healthcare workers, you need to know the case definition for mpox. Otherwise, you wouldn't be able to start suspecting an mpox case. Okay. And also, this is a probable case, surveillance case definition. So the triage and the clinical assessment is very important. And then you have to quickly differentiate them. You have to quickly cluster them in high-risk population and the clinical signs or symptoms of severity, one or more of the following signs, nausea, vomiting. I'm not going over all the details, but you also need to understand how you assess and how you screen and how you triage the patient. And also the laboratory abnormalities. And so what we are talking about here is the basic lab. I'm not talking about PCR confirmation at for instance, for the mpox virus, the confirmation. So here, the hospital laboratory abnormalities, 3 or more of the following: AST or ALT, elevated BUN, elevated WBC, and the low platelet count and low albumin. And the skin lesion severity score is mild is less than 25 lesions, moderate 25 to 99 lesions, and severe is 100 to 250 lesions. Very severe is more than 250 lesions. So the treatment of mild or uncomplicated mpox, the most of the patients, they will fall under this criteria. And the mild or uncomplicated mpox, they can be treated at home, but the IPC needs to be ensured. So again, it will be delivered by Dr. Imang after this. So the home care, isolation at home, separate from other household members, symptomatic treatment, paracetamol for severe and low pain, nutrition and skin care, and the monitoring by healthcare worker on a daily basis, such as telemedicine home visit to provide safe home care and referral if complications is preferred, and a designated person to assist self-care of the patient. So the recovering from mpox at home, WHO recommends that patients with suspected or confirmed mpox with mild and uncomplicated disease and not at high risk for complications can be isolated and treated at home. Right? Now, treatment of severe or complicated cases, that isolation and treatment in hospital or health facility is highly recommended, and consider ICU if required. And symptomatic treatment include care for fever and or pain, and nutrition, skin care, and optimized supportive treatment if required, and antivirals or other specific therapeutics against mpox must be used in clinical research context if indicated and available. I'm going to discuss a little bit even though we have a very limited time left. And the severe or complicated forms of mpox, the skin exfoliation, that the patient with heavy rash burden may develop exfoliation in severe cases similar to the partial thickness burns, and which can be significant, leading to dehydration and protein loss. Yeah. And also the ocular lesions. One of the major, the significant sequelae of mpox is corneal scarring and the loss of vision. And the patient may present with non-specific ocular symptoms such as conjunctivitis. So the case management essential items list. Again, if you're a hospital manager or if you're the healthcare workers, this is the kind of essential, the medicines list. You need to keep that in mind. So the required items for the management of the following, including bacterial skin infections. The high-risk groups for complications from mpox that include pregnant women, and other high risk for complications include the young children under age 5 and those who are at immunosuppressed patients. So this is actually very much controversial area, the recommendation on the antiviral use for mpox. So currently, none of the antivirals, there are several candidate antivirals, but they are all under the randomized clinical trials, or they have to be validated with emergency use protocol, such as MIURI protocol. So I have enclosed also the detailed the randomized control trial and also the emergency use protocol MIURI. Yeah. And the investigational candidate antivirals for mpox, as you can see that, but it's not only them, but one of them is tecovirimat. And so tecovirimat, that even though 2 years ago that WHO made conditional recommendations for tecovirimat for mpox for severe cases or like a patient at risk. However, this is the recent the findings from DRC, that it was done by National Institute of Health, NIH, USA. So the recent press release stated that tecovirimat did not improve symptom resolution in patients with grade 1. So this is a little bit scientific, but this year, this reported cases from mostly from DRC and the African continent, African countries, is different grade, different type from the outbreak we experienced in 2022. So WHO is still investigating the true effectiveness of tecovirimat against this newer, the grade 1B type of mpox. So after all, there is currently no approved therapeutic specifically for mpox, and the multiple trials are underway to evaluate the efficacy and safety of tecovirimat in patients with grade 1 and also 2. And 2 was the one circulating 2 years ago. But the preliminary results suggest little or no effect on the primary endpoint. So therefore, the priority is to ensure that the mpox patients receive the highest standard of supportive care while the scientific community continues to evaluate additional the candidate therapeutics. And safe and scalable care, which is safely optimizing the standard of supportive care, will ensure both the best possible chance for survival and allow for reliable comparisons of investigational therapeutic interventions in randomized controlled trials. So this is the summary of the clinical and the IPC resources. So thank you so much for your attention. So I'm going to end my presentation here. Okay, stop sharing. Okay, so I'm going to give the floor to Dr. Iman for IPC session. Dr. Iman, please.
Thank you, Shori, and thank you, Shori. I'm really happy to be with you today, sharing this in this very important webinar and working closely with our colleague from the case management team, because as we usually said, that providing the care and providing a good support never occur without including safety. Let me share my presentation.
And also this is, if the audience has any questions, please address that in the chat box.
Yeah, I'm trying to share now my presentation. I'm not sure why I'm not seeing it. I'm not sure why it is not, yeah, let me know, this is not, please confirm if it is like, you see my screen? No, I guess that it's...
We see your, I think it's coming up. We see your
Yeah,
file.
yeah. No, but the presentation should be presented right now. It is not a beer. Let me again.
No, it's we see the circle.
Okay.
I think it's coming up.
I guess it is coming up, but
Yes.
let me see again. It should be there here. I will try again. Yeah, try again. Is it clear right now?
Yes,
should be
now
clear.
we can put it in the presentation.
Yeah. Okay.
Very good. Go ahead, please.
So, okay. As Shori said, that maybe we couple in our activity and the supports that we are providing to the country, we are trying to work together, integrate the IBC into the case management package, because actually they are integrated. As a physician or nurse or whoever provide the care, he should know IBC and provide the IBC bit and have a skill on this, because not only for protecting the patient is important, but your protection and safety as a healthcare workers and provider is one of the importance and the utmost target that should be achieved. For Mbox, it is, as Shori said, even at the HQ level, at the regional level, and the documents that being produced, we usually align the activities and align the recommendation for the case management and the IBC together. And this is very clear in the document and the guidelines that being published by the WHO for the clinical management and IBC for the control of Mbox in June 2022. The recommendation is well aligned, the expert from here and there reviewing together, because at the end it is one package. The same activity should be applied by the same staff, and for this reason we are trying to align this activity. Actually, you have to take some consideration if we are applying the IBC measure for the Mbox, is that the healthcare associated infection by the Mbox can be occur. It is not only a communicable or a disease that can be transmitted at the community, but as well at the healthcare facility if the precautions and the IBC measures is not well implemented, and this will act and will add to the community burden. And lead to amplification of the outbreak at the level of the community as well. There are many preventive approaches to prevent Mpox from the spreading in the healthcare setting and the community setting as well, because most of the cases, if it's not uncomplicated cases and not severe, then the care can be provided at the level of the home care and the community setting. When HAI with Mpox happen, we should always aim to detect that why they are happening, investigate the cause, and use the finding to mitigate future transmission events. Particularly for the diseases that is spread in the community at the community level, something like the Mpox or CCHF or others thing of this type of the diseases, their transmission in healthcare facility is not an easy event, and not an event that can be taken very simple, because this type of infection very easy to be prevented, and therefore transmission of infection like Mpox, for example, or other type of this community based infection among healthcare workers is an event that should be investigated in a very detailed way, because mostly there is a breach in the IBC measures that can be easily corrected, and the prevention can be easily done. For Mpox transmission, it is the human-to-human transmission of Mpox occur mainly through direct contact with infectious skin and mucocutaneous lesion. Actually, the three main route of transmission till now that we know till now is the direct contact, as I said, with infectious skin lesion or mucocutaneous ulcers, and this need close and direct contact and close proximity, which is face-to-face, skin-to-skin, mouth-to-mouth, mouth-to-skin, and through respiratory droplets. The respiratory droplets, it is not mainly a respiratory infection. However, the respiratory droplet, when it's coming from the mouth, the nose, or whatsoever, the droplet is passed through the mucous membrane that usually of the patient that usually contain ulcers, and the ulcer contain the virus. So the respiratory droplet act as a carrier and nuclei for these viruses and can be transmitted and suspended into the air for a while and can transmit the infection. The other, and for me, it is the most dangerous and the most common way of transmission is the indirect contact through contaminated surfaces, clothing, or linen that have infectious skin particle. Because most of the patients, when they asked whether you have a contact or you see an Mpox patient, so we can expecting how the infection can be transmitted, most of them say no, we don't know in our and we don't face in our close proximity someone with Mpox. But the issue is because the transmission is indirectly transmitted through the surfaces, through the unclean surfaces, sharing of vomits, sharing of towels, sharing of linen, all of this can facilitate the transmission, and here the transmission become much more wider and easy transmitted. In utero, transmission of Mpox has been documented as transmission from mother to child via direct contact, and this is usually occur during birth. As I said, in the vagina and the mucous membrane of the mother, there maybe have the lesion that containing the virus, and that can be transmitted to the child later on. Healthcare worker caring for patient or handling specimen must take standard contact and droplet precautions in addition to respirator to prevent the transmission. This is the main way of preventing infection of the Mpox. The standard precautions, which is the general IPC measures and precautions that should be applied to all the patient all the time, whether they are infected or not infected. This is the main way of protection of healthcare workers as long as they are working in the healthcare setting or providing care for the patient. And additional set of precautions, including the droplet and contact precaution when there is a case suspected or confirmed to be Mpox. As this is an important consideration for person-to-person transmission of Mpox on hands and equipment, and as I said, it is very easy to catch the infection and catch the Mpox infection person-to-person, even if the patient himself is not present in the premises where the healthcare worker is working in. Commonly touched object and surfaces, high-touch surface can be a source of contamination on hands. Bed and other patient care equipment which is not cleaned with soap and water prior to disinfection may retain infectious agent. Gloves can be a barrier to contaminating the hand, but they can also facilitate the transfer of infectious agent and provide a false sense of security from transmission. Visitors can complicate environmental hygiene if they are frequently moving throughout the health facility and not washing their hands. Hand hygiene should be practiced as per the 5 moments of hand hygiene, and frequently the area where patients with contact transmissible infection are cared for. As I said, we have group of recommendation for the IPC that should be followed, standard practice that should be followed as long as we are, as a healthcare worker, providing the care for the patient. Whether the patient has infection or doesn't have infection, all the time, we should stick to this standard precaution to prevent transmission of infection to healthcare worker or from the healthcare worker to the patient at any time. This list, or the minimum list of practices that should be included in the care of all the patient, include risk assessment. We have to assess the risk. We have to screen the patient to know whether the patient may have suspected or there is a suspicion of infection or not, to add any additional precaution, as we said, we will say later on. In addition, we should have to do risk assessment to know what type of PPEs should be needed. If the patient coming with no suspected infection, with no signs and symptoms of infection, with and all the activity would be done is just providing a care with no touch technique. For example, if I like taking history for the patient or something, so no PPEs is required. Otherwise, if there is a direct touch or a direct intervention with the patient, there is some PPEs can be added. If the patient, for example, suspected to have Mpox, no, there is some categories of PPEs will be added more and more, and we will go through it in the presentation. The respiratory hygiene and cough etiquette is important. Patient placement, where I should place the patient. As Shuri said, that we will need to do some screening, sort of screening. So if we are suspecting a patient that have infection or Mpox, it should be isolated from other patient to another room, separated from others. If there is some other investigations need to be added for this patient. BBEs, the choice of BBEs, how to use them, how to put on them, how to get off them. This is very important. And the most important lesson we learned from COVID, that the BBEs alone will not protect against the infection. At the time of the COVID, we have the complaint that the healthcare worker didn't have the appropriate BBEs. However, when we went in missions and visiting the healthcare facilities, we find that is not the main problem, because most of the places that we visited, we find the BBEs, found the BBEs. But the problem is how the healthcare worker use the BBEs, how to put them in the right way, how to get off safely these BBEs to protect them against infection. Aseptic techniques and how we are approach this patient in a way that to prevent the infection for the patient. Safe injection practices is very important to protect the healthcare worker from being having the needle stick that can transmit for them a more serious infection. The safe injection practice is very important as well to protect the community from the sharp needles that is being produced in the hospital, and to prevent the infection of transmission of infection as well. Environmental cleaning, it is particularly important, and we are emphasizing the importance of environmental cleaning in diseases, particularly like the Mpox and infection like the Mpox that can be transmitted through contact. Because at the end, any type of infection, any viruses has the ability to live on the environment for a certain period of time. So if the environmental cleaning is not practiced in the way it should be, so it becomes a very common source of infection. Handling of linen and laundry is particularly important in the cases of Mpox. Waste management, as I said, is very important, and decontamination and reprocessing of the instrument. For risk assessment practices, in particularly for the cases of Mpox, we have some tips that should be followed and other tips that should be avoided. We need to initiate the screening process at the earliest point of contact with the healthcare system. Patients should be screened for with a rash and fever or lymphadenopathy, as Shori said, according to locally adapted WHO case definition. All the patients should be asked to wash their hands upon entering the health facility. A screening activity should be conducted, maintained at a distance of at least 1 meter from patient using non-touch approach. And as long as no touch approach is followed, a good distancing is present, physical barrier is present between the patient and the one who does the screening, no BBEs is required. If this no physical barrier exists, maybe the person who does the screening must to do the screening. Otherwise, there is no touch being happened. Avoid admitting patient to cohort wards treatment center when not clinically indicated or who are able to self-manage. Avoid inadequate isolation, like bed sharing less than 1 meter of distance between patient. Avoid cohorting patient with non-infectious rash. We should cohort patient who have the same symptoms, who have the same infection together. Otherwise, we don't isolate and we don't cohort. Avoid cohorting patient with suspected Mpox with patient with other symptoms, indicating infections that may be transmitted in healthcare setting. Any other infection, like having respiratory infection, another form of rash, rather than the Mpox rash, or where laboratory information determine other causes of infection. Unnecessary movement of patient with suspected or informed or confirmed Mpox should be restricted. This is the additional precautions that we need for Mpox patient, which is 2 groups of precautions together, the contact precautions and droplet precautions. What are the additional measures more than the standard precautions? The additional measure will be mainly related to the BBEs. In caring with Mpox patient, we need gown, gloves, respirator, and eye. This is mainly needed, and eye protection according to the risk assessment if there is some splashes or something. The hand hygiene is as per the the 5 moments of hand hygiene, nothing particular in cases of mpox. The patient should be placed in a well-ventilated single patient room with dedicated bathroom or toilet. If single patient room are not available, cohort confirmed cases with maintaining a distance of at least 1 meter between patients. And as I said, cohorting the patient are patients with the same symptoms and the same diagnosis. It is good if we put signage indicating contact or droplet precautions for these places or areas. PPEs include gowns, gloves, respirator equivalent with eye protection, particularly if there is splash of bodily fluid will happen. Cover exposed lesion when others are in the room during transport and if the patient can tolerate. Treat or bodily fluid and solid waste to patient as infectious waste. Attention should be paid to environmental and linen cleaning and disinfection. Here is the latest, and we will leave for you the link for the latest boosters and the latest IEC material developed by the WHO as regard of donning and doffing for mpox. It is present in 2 languages right now, the English and French. This is in the global side, and we in AMRO preparing the Arabic version, and we will circulate it among our countries and member states. In mpox, we have to follow airborne precaution in certain circumstances. Whenever we are doing procedure that related that can cause aerosol generating procedure like suction, aspiration, bronchoscopy, intubation. This procedure should be done in a very well ventilated room, negative pressure room, and we have to use respirators in doing this procedure. As I said, environmental cleaning is an issue for the mpox, and whenever we are saying environmental cleaning, we have to stick to the correct concentration of the disinfectant. This table is very nice because it summarizes the different strengths related to the chlorine or bleach, which is the most common disinfection we use in our hospitals, in our region, for cleaning and disinfection purposes. Actually, for the bleach, we have 3 strengths that can be used. The strength, or the weakest one, which is 0.05%, which is used as an alternative for hand hygiene sensitizers in the places where there is no hand hygiene agent or alcohol hand rub is available, and can be used for soaking and washing and disinfection of the linen in case we don't have a washer or a machine with a good temperature for the disinfection. We can, in this case, we can soak the linen in chlorine in this concentration for 30 minutes, then rinse, then put it in the sunlight to dry. The most common concentration.
Sorry, Dr. Iman, 2 minutes remaining.
Okay, I will finish in these 2 minutes. The 0.1%, which is used for routine cleaning of all the surfaces, even if it is in home or something. And then the strongest one, which is 0.5%, this is used for cleaning of blood spillage. For linen and laundry, as I said, that even if at home, we have to be care about the linen and laundry because it is maybe a source of transmitting the infection of mpox. All the linen and soiled linen should be collected without any shaking or doing vigorous movement. In addition to good treatment, which is either in machines, washing machine for 90 degrees Celsius for 20-30 minutes, or soaking in chlorine in 0.05% for 30 minutes. For home setting, the only tip I want to add is that because most of the patient may take or receive the home care, we should do assessment for the home environment, whether the care can be provided or not. That is to say, there is a separate place for the patient with mpox, well ventilated. The home, there is the member who will provide the care will be trained on doing hand hygiene, on environmental cleaning, as we said, and the use of mask and gloves. And most probably, and we usually recommend that the mpox patient who could able, and most of them are able to provide, to move around or to provide service care. So at least whenever they are doing the environmental cleaning, the patient himself or herself can do the cleaning for the room or the place where they live in. Mostly all the precautions for the home care setting is the same as we said in the hospital setting, but taking care that whenever providing the care for such patient to put on the appropriate PPE, environmental cleaning is very important, and to prevent sharing of household material between other household member and this patient. And this is more resources for reading and references in the case you want to return to, in the case for the mpox IBC precautions. Thank you, and over.
Thank you very much, Dr. Iman, for the excellent presentation and also sharing your expertise and lots of the information that was could be new to all of us. And also just to mention this, since there was a question in the chat box that if we can share this essential supply list that for mpox, the case management and the IPC. And even though just to let you know that this one is not published yet, but no, we would like to share that with you because basically that the end users, that whether you are healthcare workers or not, that has to be considered at your own setting and at your own country, to take that into consideration according to the local settings and also the local the availability of items, and also depending on the mpox epidemiological situation. So again, this one is not published yet, but this is going to give you the general idea what kind of supplies for case management and IPC needs to be there, be positioned. So thank you very much, Dr. Iman, once again. So let me give the floor to Dr. El Taib for the vaccine part. Dr. El Taib?
Hi, good morning, good afternoon, colleagues.
Yes, Dr. El Taib, thank you. Yeah, you can put it in the presentation mode.
Can you put it in the presentation mode?
It is a presentation mode. It looks perfect.
Okay, now. Okay,
yes, go ahead, please.
Okay, thank you very much, colleagues, and very pleased and honored to be part of this webinar. I will give you like a brief update on the monkeypox vaccines. Next slide, please. I'm not going to go through this background, like you know, the history of monkeypox in 2020, before 2022, and the declaration of public health emergency of international concern in 2022, and the outbreak that we faced during that time, and then actually lifted this situation by May 2023, and now we have another an announcement of public health of international concern declared this year because of the pandemic, or like because of the outbreak in some African countries. According to that, next slide, please. Just reminding you about the SAGE recommendations that actually declared in March 2024. According to SAGE recommendation, the vaccines that we are using now, actually they are the smallpox vaccines. So they are not mpox vaccines per se. They are the smallpox vaccines, and they are proved effective against both smallpox and mpox as well. The recommendations actually allows greatest flexibility in respect to the local risk assessment and local epidemiology. And at that time, the recommendation from the state is to use the vaccine based on the local epidemiology. And the use of the vaccine would be in the context of the outbreak in specified settings like a specific geographical area or a village or a district, and including children and other high-risk groups in the area, or even any person with a high-level risk of exposure in the outbreak setting. The second group of high-risk people that need to be vaccinated in outbreak setting are the people who are working in clinical laboratories for diagnosis of Mpox, and also those are providing care in hospitals and other health institutes, and also those in the front line working with diagnosis and taking care of people with Mpox. Again, the vaccine is recommended also for close contacts with for person with Mpox, and those mainly we are talking about household contacts. So those are the main groups of high-risk people that need to be vaccinated in outbreak setting. I'm repeating, in outbreak setting. Most of the recommendations that we are now talking about are talking about the use of the vaccine in outbreak settings. Next. And August 23, actually, this year, state has updated the recommendations. Next, and you can access this position paper in the following links, so that you can follow and you can have access to this position paper and other position papers related to other vaccines as well. Next. Again, the emphasis is on the use of the vaccine on outbreak settings. And again, also besides the recommendation for using the vaccine for laboratory personnel, working with orthopoxviruses and development of a recommendation for broader preventive monkeypox vaccination in non-outbreak setting requires significant additional data. So till now, we don't have enough evidence on the use of the vaccine in non-outbreak settings, and there is no recommendation actually for non-outbreak settings or even for vaccination, as some countries are asking still. There is no recommendation for vaccination of general public. We are only talking about vaccinating individuals and persons with high level of exposure to Mpox in the outbreak setting. Future consideration may be given to preventive Mpox vaccination. If it's
Dr. Eric, sorry to disturb you, that the audience is asking you to raise the voice a little bit.
Sorry.
Yeah.
Is it better now?
Yes.
Okay,
It's better
sorry
now.
for that.
Yeah.
Okay, sorry for that. Okay. So I'm just repeating that in the new SAGE recommendation is talking about the emphasis and importance of using the smallpox vaccines in outbreak setting. So till now, we don't have any recommendation on the use of the vaccines for preventive Mpox vaccination. However, still there is no evidence on the use, and people are looking at actually having more data on the use of the vaccine in non-outbreak setting, and also for use it as a preventive measure as well. Next. Next slide, please. Sorry, can I have the next slide? No. Okay, great. So for the preventive use of vaccination for laboratory personnel and also for frontline health workers working in health institutes providing care for Mpox patients, actually we don't know about the duration of the protection of the vaccine. So it is not yet fully characterized. And because of that, people are like trying to agree, and they agreed already on having like repeated exposure to the vaccine like every 2 to 3 years for people working in laboratories with assigned for diagnosis of Mpox viruses and all general or syphilis viruses as well. So for now, we are like recommending that the vaccines to be used every 2 years for people working in laboratories and for those working in providing care for patients with Mpox. Next. So the vaccination in the context of Mpox outbreak, vaccination is recommended for persons at high risk of exposure to Mpox during outbreak, and to allow the greatest flexibility with respect to the local risk assessment, varied modes of transmission and response options. Population to consider for vaccination may include first, based on the local epidemiology, members of a geographically defined areas for specific communities. For example, people living in a specific village or specific geographical boundaries, including children with documented high risk of exposure to person with Mpox. Again, part of people who is like experiencing high risk of exposure are those working sex workers. This includes gays, bisexual, MSM. Those are like at high risk of getting Mpox, and they are considered part of the targeted groups for vaccination. Health workers also at risk of repeated exposure, and those include, in addition to the clinical laboratories, include healthcare personnel performing diagnostic testing or providing care to Mpox patients. And the third category are the contacts of persons with Mpox. And those ideally, those are the household contacts. And those should be like identified and given the vaccine like 4 days of the first exposure. The use of the vaccine as a preventive measure is very effective if it is given pre-exposure. So giving the vaccine after the exposure, really it is less effective, okay? But again, people are like trying to consider, giving it within the 4 days of exposure, that might be having some effect. So those are the categories of persons who are like at high risk of getting Mpox and should be vaccinated, and the use of the vaccine here can be recommended as a preventive measure for those people, again, in the context of outbreak setting. So we are repeating, and this even consideration of those high-risk groups is within the outbreak setting. Next slide, please. So this slide talking about the choice of the vaccine. However, WHO recommends that the immunocompetent, non-pregnant individual, they can use the vaccine. So there is no recommendation now for the use of the vaccine for immunocompromised patients or patients with HIV, or even for pregnant women or lactating women. And to use the vaccine for the immunocompetent, non-pregnant, we should also make sure that we are using some vaccines with high record of safety, like those vaccines which are, we call them non-replicating vaccines, like MVA-BN vaccine. This is a vaccine produced by a Danish company, and it is like one of the safest vaccine to be used. It is also recommended for those over the age of 18 years. It has a very good safe record as well. Also, WHO is recommending using minimally replicating vaccines like LC16, and this is a Japanese actually vaccine, and it is now available even for donation by the Japanese government. And it is one of the safest vaccines, as well as it is one of the cheapest. It's very actually cheap compared to other types of vaccines. For MVA, I think the dose is $60 to $70, For LC16, the dose is only $1. It's only $1 per dose. Replicating cell cultures derived vaccines like ACAM 2000, those are like somehow having a lot of adverse events and are actually also less expensive than the non-replicating vaccines, MVA. The FDA, US FDA is like using another vaccines called Genius vaccine. Genius, like one of the very expensive vaccines actually. It costs around $140 per dose, but it is a very safe vaccine and it can be used at all ages and also can be used for immunocompromised patients, including HIV patients. So this is registered in the US FDA and it is one of the top vaccines regarding preventing of the Mpox. The contraindication of a smallpox or monkeypox vaccine. So co-administration of a smallpox vaccine with other vaccines that we are using in routine immunization. There is no actually evidence on that, and there is no actually enough information about the use of a smallpox or monkeypox vaccine and co-administration of those vaccines with other vaccine used in routine immunization. So it is better to be avoided at the time being. So this is one of the precautions that we had to take. Next slide. For contraindication, again, contraindication, unlike any other vaccines, the contraindication include allergy to any vaccine component. This is like should be also noticed, and individual with advanced immunodeficiency or severe immunosuppression also should not be vaccinated. Individual with some skin conditions like atopic dermatitis also should not be vaccinated. Those, as I mentioned, with some allergy to some components of the vaccine should not be vaccinated. Replicating vaccines like the ACAM 2000 vaccine should not be used in infants. So those are general and very serious actually contraindications that need to be strictly followed when we are administering the vaccine. Next slide. This slide actually shows the vaccines licensed so far. You know that WHO in 7th of August has declared the announcement of emergency use listing. And emergency use listing is a procedure that used by WHO to give like temporal approval for use of some vaccines or medical products during emergency. So this is just a special approval for the use of the vaccine during emergency. It is not a pre-qualification. So pre-qualification, we know there is a pre-qualification mechanism for vaccines, for drugs, for medical products. And this pre-qualification, like testing all and assessing all safety and efficacy of the vaccines and medical products, and also trying to avail this information for all countries in order to support countries in procurement of good quality vaccines and good quality drugs. So this procedure, the first step in this procedure is the emergency use listing. Emergency use listing also will allow WHO and other partners to have a global coordinated mechanism to ensure equitable distribution of vaccines and equitable access to vaccines. Because if the vaccines are left for the market supply and demand, some countries might not have access to those vaccines. And that is why there is a need for ICG-like mechanism in order to avail vaccines to those countries in need. So far, those are the vaccines listed in the emergency use listing. The top vaccine is MVA PN. but it is as I mentioned, it is a Danish company, and MVA. It is called Bavarian Nordic. It is non-replicating vaccine, and it is very safe, and it is like recommended for all individuals above 18 years of age. It's 2 doses, like given 4 weeks apart. The first dose, if given for pre-exposure, it can have an efficacy of 72%, and the 2 doses, if given also, can be like having almost 82 to 86% efficacy. So it is one of the safest vaccine and one of the high efficacious vaccines that can be used. The next vaccine in the list, and as I mentioned, the cost of this vaccine is around $60 to $70 per dose. The second vaccine in the list is LC16. It is Japanese vaccine. It is minimally replicating, and it is one of the also safest vaccine. It can be given for all ages, and it is only single dose, and it can be actually there is several million doses now donated by Japanese government, and some countries can access these donations through WHO and other third parties. And it is the cost of this vaccine is only $1 per dose. The third vaccine is ACAM 2000, which is also registered in USA for over 16 years of age. It is a single dose, and there is some several million doses available and can be procured. And it is less costly also than the MVA-BN vaccines. There is other also box vaccines that is available, but there's not enough information about this vaccine. Sorry. Next slide. Okay, so how countries can access those vaccines? You know, for all member states, there are like 4 mechanisms to access mpox vaccines. The first mechanism is the direct procurement. Direct procurement, that means between the manufacturers and countries. And this is now available. And now I think most countries now are relying on this mechanism in order to get the vaccine. And there is some supply available for commercial procurement. And this is just between, there is no place here for third party, it is just between countries. And countries can approach the manufacturers directly for any type of the vaccines that is available now and can use it. It is recommended that people should look for those emergency use listing and to look at the vaccines which are already listed in this emergency use in EUL, and to look for those manufacturers with abundant qualities. As I mentioned, we have MVA, BN, and we have LC16. Still, there is some doses which are for commercial use. However, people are like trying to ensure that we have enough supplies for countries that are facing mpox outbreak in Africa. The second mechanism is the pooled procurement, and this is like manufacturer to a third party, and then from the third party to country. And some group of countries, like in Gulf States and some other areas in Bahu, they are like using this mechanism for procurement in order to ensure that they have enough vaccine for all their member states. The third mechanism is coordinated donation, and this is like some of the producing countries would like to donate some amounts of the vaccine, and this should be also through a third party. So sometimes even we have some global mechanisms that ensure equitable access to vaccine, and some donation has given to like some sort of ICG-like mechanism, and they can work to manage those donations as well. Bilateral donations, this can be directly also between countries. So country to countries, they can have that bilateral donation. And some countries are interested to donate some doses to other countries as well. So those are the four mechanisms that are available for access to mpox vaccines. However, now we have only the direct procurement. By declaring the EUL, now this is the first step in the WHO with other partners can establish a global mechanism for ensuring equitable access to vaccine. And then we will see, until now, I think there is 6 manufacturers registered in this list. And I think also for pre-qualification, WHO is like reviewing documents and assessing MVA BN, and it will be the first candidate for pre-qualification. So MVA BN will be the first candidate for pre-qualification. Other 6 products are already listed in the UAL, and also people are collecting data on that and doing a lot of assessment in order to ensure that we are using vaccines of high quality. Next slide. I think that is all. Thank you very much. I will stop here. If you have any questions, I'm ready to respond. Over to you.
Thank you very, very much, Dr. Ertaib. It was an excellent presentation with a lot of very practical information as well. That personally, I learned so much about the different vaccines licensed for use against mpox, and also how each country can have access to each. It was I think we all learned a lot from your presentation. Thank you so much. So if anyone has any questions to 3 of us, case management, IPC, vaccine, that this is the last opportunity for you to address it. So please feel free to open your mic and address your questions if you have any, or if you are too shy, that you can also drop your question in the chat box. And we are already 10 minutes past from the scheduled time, so we have to close it very soon. So if no more questions, then we are going to end today's the regional webinar. Today's topic was mpox, and thank you so much again for Dr. Iman and Dr. Ertaib. I feel so lucky and privileged to have colleagues like you guys. And so together that we continue to make this streamlined and harmonized efforts to deliver more comprehensive information and guidance to public and also the people in the region and beyond. Thank you very much. And so we will see you again in 2 months from now. Thank you.